Then I'll ask Shefali to talk about the mainly eagle study, but the clear lens extraction or early cataract in angle closure disease.
So thank you, Dr. Rajul, for giving me this opportunity. Good morning, everyone. So I am going to talk on role of lens extraction in PACD. What is the implication of eagle study? Now, since the eagle study has been published and it has propagated the role of clear lens extraction as a first line of treatment in primary angle closure glaucoma and PAC, where the pressure is more than 30 millimeters of mercury, it has sparked the controversy regarding the role of LPI as a first line of treatment. If you see the literature review, there were few articles which demonstrated the modest reduction in the intraocular pressure, and also the number of medication also reduced after doing the cataract surgery, but they were all retrospective study. Them et al., he did prospective randomized control trial on 50 eyes of 50 patients and who were over 50 years with medically uncontrolled primary angle closure glaucoma with no cataract, and the patients were randomized either to the phaco-IOL group or TRAP with MMC. It was 2 years follow-up, and what we found was that the intraocular pressure reduction in both the group, that is phaco-IOL and TRAP with MMC, that was comparable. In phaco-IOL group, though the number of medication, it was still 1 compared to 0 medication in the TRAP group, and in phaco group, 3 patients had to undergo TRAP, when in TRAP group, number of complications were there, including cataract, but usually they were manageable. But we must remember that if you plan, this was in the study which THAM did, they were routine cataracts. They were not the angle closure glaucoma patients where the cataract surgery is much more difficult. So coming to the eagle study, where the aim is primary aim was to study the quality of life, intraocular pressure control, and the cost effectiveness, and it was 3 years after randomization. Patients were randomized into clear lens extraction and the standard of care, which was laser PI followed by medical surgery or any other laser procedure as in when required. Surgery in phaco-IOL group, it was phaco with monofocal IOL, and in LPI group, laser was done within 60 days of randomization, and iridoplasty or medical treatment as in when the treating physician decided. Based on these results, you can see this based on these results, of course it is p-value is significant, pressure reduction is only nearly 1.18 millimeters of mercury. So based on these results, eagle study, it concluded that the clear lens extraction should be considered as the initial treatment for primary angle closure glaucoma and PAC with raised IOP. Now coming to the crit analysis, now if you see in the clear lens extraction group, eyes are little bit short, that means these eyes were little bit hypermetropic because their axial length was short. Refractive error was little bit more compared to the LPI group, and we know we all are doing cataract surgery as well. And once we operate patient, especially patient who is hypermetropic, and you know that how the patient is satisfied after doing that when we make the patient immetrope. So especially the hypermetropic patients. So here what we need to consider was the difference in this refractive error post-operative responsible for the improved quality of life. Coming to the quality of life, this difference was, if you see, difference was 0.052, which ultimately comes down to 5%. So the question that we need to consider is this 5% difference in the quality of life relevant in our day-to-day life? Based on these two findings, eagle study concluded that the clear lens extraction can be done. If you see the IOP, the difference was 1.18 in the clear lens extraction group, only this much reduction. If you see, the hypothesis of this study was to have the difference of 1.75 millimeter of mercury between the two groups. So to begin with, the study actually failed to meet the criteria of their own hypothesis also. Coming to its limitation, if you see these are the baseline gonioscopy findings, patient this many without indentation, and if you see at the final visit, nearly 60, this is the missing gonioscopy at the end of 3 years. Nearly 60% of the patients did not have gonioscopy, and we know this, we are studying This is the study in the angle closure glaucoma, where gonioscopy is one of the integral part, because even if the progression in synechiae is considered as a progression. So, does this study provide any extra information on the progression of the disease? You know, when we are dealing with the angle closure glaucoma or any glaucoma, it is not only the progression in the disc and field, but we have to look, is there any progression in synechia also. So, in angle there is no additional information, because in nearly 60% of the patient gonioscopy finding is missing. Intraocular pressure reduction was only 1.18 millimeters of mercury. So, which we have to think whether it is a clinically relevant, and is any invasive surgery, that too in difficult and challenging patients, you know, challenging, because in angle closure glaucoma you must have done the cataract surgery, you know, it is much more technically difficult and challenging. So, is any invasive surgery advisable to achieve this reduction of 1.18 millimeters of mercury? There is very limited information on the disc and field, and most important is that this study where they did the clear lens extraction, there is no information on the lens biometry, no information on lens vault and biometry, where actually if this information was there, this could have provided that which subset or which subgroup of the patient would have got benefit after doing only the cataract surgery. So, coming to the discussion. So, we know that in angle PACD there are basically two mechanisms, pupillary block. In 2/3 of the cases it is pupillary block mechanism, and in 1/3 it is non-pupillary block. It is actually always the multiple mechanism which works, there are at play, but mainly it is a pupillary block, but there are always one combination over the other. And at this point of time what we are doing is LPI, which is our current practice for the management of PACG and PAC. And it is basically to break this pupillary block mechanism. If you see theoretically, if you remove the lens, you know, especially in the predisposed eye, where there is a lot of crowding of the angle, once we remove the lens, then definitely it will relieve the crowding of the angle, it will also relieve the pupillary block. But we have to think whether it is better to just to relieve that pupillary block, whether we need to do LPI, which is a non-invasive and a safe procedure, versus clear lens extraction, which is invasive and technically more challenging compared to LPI. However, if you want to do cataract in this type of patient where it is visually significant cataract, then it is totally different decision. Even Cochrane review also suggested that despite the biological possibility of benefit, there was no published evidence for the effectiveness of lens extraction in chronic PACG. Even World Glaucoma Association also states the same, that there is insufficient evidence for deciding which cases with PACG should undergo cataract surgery alone, and clear lens extraction or early cataract surgery can be considered in eyes with progressive increase in lens thickness leading to shallow anterior chamber depth, where angle closure is attributable mainly due to lenticular mechanism. So, to conclude, clear lens extraction or early cataract surgery can be considered in eyes with progressive increase in lens thickness leading to the shallow anterior chamber depth, where angle closure is attributable mainly due to lenticular mechanism. So, first we have to make sure that this is because of lens, lens is the responsible, lens is the culprit, and that also we can make sure only after doing the LPI, because that pupillary block in 2/3 of the cases, the main cause is pupillary block. So, that can be relieved mainly by LPI. So, the eyes with high lens fault we can consider. However, we need more information of high risk groups based on the lens fault and lens thickness, who are likely to benefit from the early cataract surgery. Till then, I think better to continue doing LPI as a first choice. Thank you.